Governments have given drug companies billions of dollars to develop a COVID-19 vaccine. Yet, millions of people won't be able to access or afford the vaccine because these same companies have complete control over the price. We need a vaccine that's free and available to everyone, everywhere. Where you were born and how much money you have shouldn't determine whether you live or die. It's time for a people's vaccine.
Warm greetings and hello to everyone in Asia. Welcome to today's online media forum called The State of COVID and Vaccines in Asia, Why the World Needs a People's Vaccine. I'm Antoinette Toss, Oxfam Philippines Ambassador for Resilience, and I'm honored to be your moderator for today. Since the COVID-19 pandemic swept across the globe, it has exposed the glaring inequalities affecting people, especially those who live in poverty and other vulnerable conditions. Now, one of these is the dramatic inequities in COVID-19 vaccine supplies and technologies, which is an urgent step to fight and ultimately end the pandemic. Many countries in Asia are witnessing now a catastrophic new wave of COVID infections, which is further worsened by shortage of vaccine supplies and collapsing health systems. The unequal distribution of vaccines is one of the major roadblocks in global vaccination efforts. Now, since vaccination efforts started this year, many poor and developing countries in Asia are still lagging far behind in getting their people inoculated. Now, this is a stark contrast to rich countries, which have already secured enough doses to vaccinate their entire populations nearly 3 times over by the end of 2021. Today, we will shed light on this issue and hear straight from the experts and representatives of those countries who are in the epicenter of the COVID-19 pandemic in Asia. Before we dive into these conversations, if you would like to join the conversation on Twitter, please use the hashtag #PeoplesVaccine or tag @people_vaccine. Let's now welcome Dinah Fuentesfina, the People's Vaccine Alliance Asia Interim Co-Coordinator and Campaign Manager of Action Aid International.
Thank you, Tony, and hello, everyone. Good morning or good afternoon, wherever you are. So we are the People's Vaccine Alliance Asia. We are a network of around 150 organizations across Asia and part of the ever-growing global movement, the People's Vaccine Alliance. As you know, the WTO, or the World Trade Organization's trade-related aspects of intellectual property, or TRIPS Council, met yesterday and the other day. And the G7, the group of 7 countries, the richest economies in the world, are meeting in Cornwall tomorrow, this weekend. So that's why the People's Vaccine Alliance in Asia is holding this online media forum. We want to ring the alarm to government leaders to support a temporary waiver of intellectual property rules until the majority of the world's population receives effective vaccines and develop immunity to this cruel disease called COVID-19. Second, compel pharmaceutical companies and rich countries to join the WHO's COVID-19 Technology Access Pool, or CTAP. And the third, we want to show the realities faced by us, by countries in Asia who are at the brink of the healthcare system collapse amidst the rising number of COVID cases and slow vaccine rollout. As they say, the countries in Asia and the populations of Asia are literally gasping for breath. So thank you, everyone. Thank you for being here. And back to you, Tony. Thanks.
Thank you very much, Dinah, for that inspiring message. And now let's go to the heart of today's event. Our first speaker is Angela Changela from Oxfam, India. Angela leads the work on inequality, health, and education in Oxfam India. She also leads the Fight Inequality Alliance in India. Oxfam India, together with a Forum of Medical Ethics Society, have recently submitted a petition to the Prime Minister and endorsed by over 600 academics, prominent activists, organizations, and health workers asking for a people's vaccine in India. To talk about the state of COVID and the vaccination rollout in India, here is Angela Taneja. Good afternoon, Angela. We are live. We are so grateful to have you with us today.
Sorry, can I have screen sharing?
Oh, yes, ma'am. To our tech team, could we help Ms. Taneja with screen sharing, please? Thank you very much.
Okay. Still not there, but let me, I'll keep trying and talking. So India is a slightly different from many other countries in the world, given its sheer size. So therefore, if one looks at the reality of vaccination in India, we have a slightly anomalous situation where we have simultaneously the sorry, technology is failing now. Simultaneously,
we can see the screen now.
Yeah, we are simultaneously among the largest number of people vaccinated in the world. We've crossed the numbers of vaccination in the United States. But when it comes down to the numbers of people vaccinated, and that too fully vaccinated, we drop all the way down to 3.3%. So therefore, sure, in the real numbers, we have a fairly high rates of vaccination. But when it comes down to reality, then as a share of our population, we have very far to go. Again, vaccination rates, pace of vaccination for India falls very short compared to the rest of the countries in Asia. Because fundamentally, it's not just the sheer number of people in a country, but it's ultimately whether people are actually receiving vaccines. Where are the problems? 4 or 5. On one level, there is the question of procurement. The government of India aims to have 2 billion doses by 2021 to ensure that everyone is vaccinated. But let's not forget, 3 out of the 8 vaccines that are in production in India and are being, only 3 are approved and 2 are in early stages, 3 in late stages. Therefore, even if, as the summary to the right shows, a fairly large, the production capacity is considerable. Fundamentally, there are only 3 vaccines which are ready to use. If you look at them, then we are at our production capacity and our manufacturing capacity, therefore the possibility of getting vaccines is roughly half of what is needed. Yes, the government has made efforts. Yes, it has promised advances to our domestic manufacturers to boost production. Yes, it's initiated a voluntary license has been doing matchmaking for voluntary licensing of some of the domestic vaccine produced vaccine, but fundamentally the elephant in the room is our current manufacturing capacity is of vaccines that are ready to use is only half of what is needed if we have to vaccinate everyone. And there is also the need to address raw material shortages, because intellectual property waivers are needed not just for the vaccine, but also for the further things from that are needed to manufacture the vaccine across the supply chain. Elephant in the room for that is the question of manufacturing, and more specifically that of the two manufacturers that are licensed to distribute right now within India, which are Serum Institute and Bharat Biotech. By all accounts, current pricing of vaccines is predatory. Estimated profit margins are for vaccine manufacturers are somewhere between 2,000 to 4,000%. Serum Institute, which produces the AstraZeneca vaccine, admits making profits, admits that it would be is eager to earn super profits. Bharat Biotech CEO said that the vaccine will actually cost less than a water bottle, and instead it's costing us 1,400. It's now pegged at 1,400 rupees per shot for a 2-shot vaccine. Serum Institute, AstraZeneca, this so-called not-for-profit vaccine, has earned $4 billion, and Adar Purawala, who heads it, his own personal wealth has doubled during the pandemic. Certainly not signs of a company making losses and doing philanthropic gestures for the benefit of humanity. Let's not forget AstraZeneca was 97% publicly funded. Let's not forget it benefited from publicly funded research. Let's not forget it had unpaid volunteers to test the vaccine. Let's not forget the agreement of AstraZeneca with Oxford Institute, from which Serum Institute benefits, is that it will be a not-for-profit vaccine. Ironically, new manufacturers are, in addition to the proven track record of profiteering, are also asking for an indemnity. And now older manufacturers like Serum Institute are also asking to have their own share of the pie at a time when there is underutilized public sector unit capacity. Public sector vaccine manufacturers facilities like this facility in Tamil Nadu is standing idle while the private sector is making hay while the sun is out. Therefore, we need more transparency in agreements. We need more involvement of existing other companies to be involved, including the public sector. And it's time for the government to look at compulsory licensing if manufacturing capacities can't be improved. And that's again a good case in point for the need for a global IP waiver, because obviously vaccine manufacturers in India aren't operating in a not-for-profit philanthropic. It's not a people's vaccine in India. Distribution, the government is now committed to 18+ vaccination, which is free. However, estimates suggest that anything between 1.5 or 2.5 years will take for all adult population to be vaccinated. Lot of demand for children to be vaccinated, given schools have been closed for 1.5 almost years now. But there is not enough transparency of allocation of vaccines to the states in a federal system. There need to be plans to address vaccine hesitancy, and there needs to be more there's been a reliance on centralized digital modes of enrolling people for vaccination, which doesn't work given the digital divide. and given that we don't even maintain records whether rich versus poor are immunized for reasons that's important, I will come to on the next slide. And we don't have decentralized district level plans and social mobilization strategies to ensure the poor, the marginalized, the tribals, the indigenous people, the hard to reach populations are actually reached because they also have an equal right to a people's vaccine. Vaccine equity is an issue. Yes, rates are low, but at a time when the rates are low, the government has effectively reserved 25% of doses for the rich through setting aside 25% of all vaccine doses to be given to distributed through private hospitals. Until now, track record is in May, 80% of doses were distributed in the private sector, were only distributed in the larger cities within India. And in fact, 50% of doses were just distributed by 9 big corporate hospital chains. Big pharma, big hospitals are making hay again at this time of crisis. We have not adequately covered existing vulnerable populations. We don't even maintain records of it. We do have evidence of gaps in vaccination. We have evidence of almost a 6 to 8% vaccination gap between men and women. Therefore, we need to roll back the private sector reservation. We need to reach vulnerable groups, and we need to deal with the fact that inequalities are opening up between states and also even more so between districts. Unlike a lot of other countries, one doesn't need to convince India to have a global IP waiver, because it's been, along with South Africa being the one leading on this. But we as civil society support the temporary relaxation of the IP waiver, as well as the need for the support for the CTAP to facilitate pool of IP technology and as well as technology transfer. It's time to lift bans on exports and redistribute vaccine stocks as well. That's it from India. This is based on a wider mobilization on the people's vaccine that we have had in the country, from at least 12 citizens from at least 20 provinces have endorsed these demands that one is making. We are lucky we have had a change in policy. We've been successful in having a change in the vaccination policy only 2 days back. So therefore, the government does seem to be amenable to change, which is a good thing for us at this point. But we have a long way to go from a vaccine equity and to ensuring that everyone has access to a people's vaccine. That's it.
Thank you very, very much, Angela Taneja from Oxfam India. And thank you for sharing the state of COVID and the vaccination rollout in India. And I completely agree. And I feel like that is really the priorities that we are facing right now, really being able to create more transparency, more support, more open sharing of knowledge, but not just that, also considering all the gaps as the plans are made for ways forward. And we are truly grateful for all the work that you do. And we hope that today can somehow be a large step forward in finding solutions and concrete solutions to what needs to be done. Thank you very much, Ma'am Taneja. Now, before we proceed to the next speaker, I would like to remind everyone to please type in your name and organization together with your comments and questions in the chat box. We will be reading some of your questions later during the open forum, and we hope to really address your concerns, your thoughts, and your inquiries. So we welcome questions from all of you. Now, moving on to our next speaker from Indonesia, we have Aditya Wardana, the Executive Director for NGO Indonesia AIDS Coalition, a community-based organization which aims to fulfill the rights of people living with HIV. Aditya led the team in advocating for several life-saving medicines to be included into the Indonesian universal health coverage and government budget. From Indonesia, let's welcome Aditya Wardana.
Thank you, Tony. Let me share the screen here. Can you see my screen?
Yes, you are on, Aditya. Thank you very much. And we can hear you loud and clear as well.
Okay. Thank you, Tony. My name is Aditya Wardana, and like I mentioned, I'm the Executive Director of the Indonesia Coalition. Our organization was established in 2011. Our focus on the fulfillment of the human right for people living with HIV and other key affected population. In Indonesia, we work closely with the government, especially the Ministry of Health and also the Office of the President. And currently, I'm providing the technical advice to the Health Minister related to the progress related to the trip waiver proposal. And our organization is also working with several international development partners. COVID-19 first reported in Indonesia on March 2, 2020. And since then, several government policy and regulation have been issued, including mobilization restriction, strict health protocol, and vaccination to protect our citizens from COVID-19 and prevent the mortality due to the COVID-19. So, despite of the effort from the government, a year into the pandemic at this moment, Indonesia had faced with 1.8 million confirmed COVID case. This is the cumulative case for June 9, 2021, with almost 100,000 active cases and more than 50,000 mortality recorded. Moreover, as if the current existing COVID threat was not enough, we are now threatened with new COVID variant because like we already know that this virus is rapidly have mutated. And now with 3 of them have been identified in several areas in Indonesia. So we are now struggling to contact tracing the patient with the COVID, and we perform the genome sequencing to see which type of virus of COVID or SARS-CoV-2 that infected them. This is the variant of concern that already entering the Indonesia. There are 3 that actually now we are aware of. As you can see in the slide, Indonesia now reported 12 cases of B117, or WHO just renamed it with Alpha, and also 1 case of B1351 as a beta. There is 1 case. And for the Delta of the virus, of the mutation of the virus, we saw that now we have 2 cases. But this is only the case that had been identified. We need to really doubling our effort on contact tracing to ensure that we know what kind of pandemic landscape that we face in Indonesia. Related to the vaccination, Indonesia has 270 million citizens, with 10.2% of them are in the poverty line, according to Central Statistics Agency report of September 2020. And this number, the poverty line, had increased 0.97% since the previous year. This increase was suspected due to COVID-19. Limited vaccine has forced the government to make a prioritization. Currently, Indonesia is on the phase 3, but prioritized citizens don't always mean getting vaccination right away, because this is depend on the availability of the vaccine itself. In this case, we are monitoring that a citizen with comorbid, including people living with HIV, are also queue on a long line to get vaccinated. In parallel, several studies done by ISC and other HIV organizations show that HIV community was also heavily impacted through socio-economic aspect as well as the obvious health aspect. This call for an immediate response to tackle COVID-19, in which the most reasonable and doable action was with vaccination, we believe it. Unfortunately, due to the limited availability of the vaccine to buy, Indonesia government had to conduct vaccination in phase. Up to date, 80 million people had received their first vaccine, and 11 million people had been fully vaccinated. In Indonesia, all of the vaccine that being used in Indonesia, we got it imported from outside Indonesia. And this number is only conclude to less than 10% of our country population. While the vaccine product used in Indonesia are, we use two kind of vaccine for the public program and one vaccine for the private program. For the first two products, Sinovac and AstraZeneca, were used in the government-free vaccination program. And Sinopharm were offered for private vaccination at the price of 1 million rupiah, or it equal around 71 US dollar for 2 shots of vaccine. The urgent need of vaccination was heavily affected by the inequality of vaccine distribution, in which our president already mentioned, and some of the world leaders already mentioned too, the rich and developed country had monopolized 83% of the world COVID vaccine stock. And our president, President Jokowi, had criticized this on the Global Health Summit this May, as the 83% of the global vaccine dose had been distributed to rich countries, while the other 47% of the world population had to share the remaining 17% of the vaccine stock in the world. So this is the long-awaited trip waiver. Actually, our country is really waiting for this trip waiver, because under the proposal of the trip waiver that proposed by the India and South Africa, I quote the publication made by the MSF, it goes way beyond patent on drugs and medicine, because as we know in the proposal, the original proposal, it consists of the patent, the copyright, the industrial design, and the access of the undisclosed information. And this is have aim that every country, every possible country can produce the vaccine without any legal sanction of it. And this proposal of the trip waiver, it includes everyone, every country. There is no limitation like other mechanism that sometimes only include several countries, for instance. And it will speed up the COVID response. We believe that the trip waiver proposal will speed up the COVID response. And it will make COVID-19 medicine, vaccine, and medical tools more affordable. And the most important, the trip waiver proposal put government in the driving seat, not the pharma company in the driving seat. So on 10 May 2021, after discussing with our health minister, our Ministry of Foreign Affairs, we had convinced them that Indonesia to become the co-sponsor of this trip waiver proposal. And Indonesia has been added to the list of sponsors of the submission of trip waiver in the document IP/C/V669. I'm trying to quote what our president has been always speak in Indonesia and also in the global event. Indonesia has decided to become one of the co-sponsor of the proposal of the COVID trip waiver proposal. Indonesia also hope that other G20 member country can provide the same support. This is the Indonesian readiness if the trip waiver proposal approved. Yeah. We have 6 manufacturer with a big capacity, with massive production, and we are ready to produce the COVID-19 vaccine, therapeutic, and diagnostic. And the health minister itself already stated that we are ready to become a hub in the regional level once the trip waiver proposal approved. This is the statement that made by our Ministry of Health. Currently, we have 6 manufacturers with production capacity of more than 500 million doses. And Indonesia is eager to ready to contribute because we know that as the largest vaccine manufacturer in Southeast Asia, we indeed have the capacity to upscale our vaccine production to meet with the regional demand. But unfortunately, in Indonesia, we can only produce vaccine with technology platform virus protein base. Indonesia don't have access to vaccine with vector base or nucleic acid base like messenger RNA. So we are in Indonesia looking forward to have access to those technology, and we are ready to contribute. In conclusion, we heard that last night that the TRIPS Council has agreed to move to text-based negotiation. This means that the plea of 4 TRIPS waiver for COVID-19 health products are progressing, because the only way to end the pandemic is when all countries are safe. We are sincerely hoping the benefit of the people will trump the profit-making orientation, and solidarity for greater good will be prioritized. Only then will we have a better chance to beat this COVID-19 in solidarity. Thank you. Back to you, Tony.
Thank you very, very much, Aditya Wardana, Executive Director, Indonesia AIDS Coalition. And thank you once again for emphasizing the urgent need to be able to provide access to these vaccines to everyone, everywhere, and most especially to the vulnerable communities. And of course, to those that are most affected. And speaking and hearing about all these facts about how we can really empower more people if only we don't allow the monopolization of vaccines in certain countries across the world, sharing the knowledge, and of course, providing the access, especially for the most vulnerable. Thank you very much once again, Aditya Wardana. We also would like to thank everyone for your comments and questions. We will have, of course, some time later to answer them and discuss more of your queries. Now, next, we would like to talk about the state of COVID and vaccination rollout in the Philippines. We have the chairman of the board of trustees from the Medical Action Group and the vice president and executive member of the Philippine College of Chest Physicians. Let's all give a warm welcome to Dr. Nemuel Fahutagana.
Oh, for a while. Just
Good afternoon, Dr. Fahutagana.
good afternoon. Can I just correct the introduction?
Hi, yes, sir.
I'm not the vice president of the Philippine. I'm only representing the Medical Action Group, please, and the coalition in the Philippines.
Thank you very much for graciously clearing that, sir. We hear you loud and clear, and we see your presentation as well. You may proceed, sir.
Okay, good afternoon, everyone. So I was tasked to provide the information on the Philippine situation, but our focus is basically on the impact of COVID-19 to public health and public health delivery, resulting to public health crisis. So I titled this presentation, COVID-19 Death and Public Health Crisis, Philippines, Life and Death. So probably it would already give you an idea of where we would like to focus our discussion. Let me start by providing you with the COVID-19 situation in the Philippines. So as of the moment, as of yesterday, actually, we have 56,000 active cases, and these new active cases added yesterday, June 8, or the other day, brought us to a total of 1.2 million new total cases as of June 2021. And of course, we have a record death of about 20,000 since COVID started in 2020. With all these cases and with all the death that we have and the continuing trend of increasing For example, COVID cases, especially moving towards the south. We will show here why we are seeing a drop in cases in NCR, the rest of the zone. We are documenting a number of cases, active cases now, new cases in you can take our coverage, for example, in Mindanao. Like say, I'll just focus, for example, in Caraga, which will have the highest in Mindanao. Only 2.4% of the population of the region had been adverse to those, and only
Dr.
you also have to look for.
We're experiencing some interruption in the network. And it,
the autonomous in audio. Hello? Hello?
yes, sir. I think your presentation has also frozen slightly, but I can hear you better now, sir.
Okay. So actually, I'm okay on this slide. So you also notice that, for example, in the autonomous region of Muslim Mindanao, we only have 0.4% of our population have received the first dose, and about only 3,000 or only 0.1% with the second dose. If you look at the Western BS, we also is noticing an uptake in the number of cases. There's only 1.6% of the regional population that have received the first dose. Again, only 0.4% of the vaccine. And we go down to Central Visayas, the same thing is almost the same pattern. And compare that, for example, to our vaccination effort in National Capital Region and Luzon. Of course, the Ilocos region that I used here as an example is still almost with the same trend in relation to coverage. And Manila will have about 6.8% of the population covered. But just read this morning in the newspaper that actually Manila or the NCR have already consumed most of its allocation, and they will have to wait for next week to start the revaccination program. So as I said, while we are seeing an uptake in the increase in the number of COVID cases in Visayas and Mindanao, that's also where the vaccine is not widely made available, or the distribution is still not very, let's say, wide enough to even consider some or to relax even in some of our concerns related to COVID spread. So in total, we have only provided 4,000 or 4 million doses of COVID-19 for the first dose, and only about 1.5 received second dose. That's very far from our target of 70% of the country's 110 million. So that will be about, as of this time, we only have about 4% of the population receiving. So very far from the herd immunity or that we want to achieve if ever we would like to really relax a little bit, feel relaxed that our system is improving. We compare, for example, our country's vaccination rate compared to our neighboring countries like Cambodia, Singapore with 69.19%, Cambodia is 28%, and Philippines actually, and Vietnam is there in the lowest group of only 5.44% or 1.28% of population vaccinated. And that's actually per 100,000 people in the total population. And if we are comparing our vaccination rate with the rest of the world, for example, like European Union and United States, we are ASEAN, including the Philippines, are way, way down. And this tells us about the inequality in COVID-19 coverage. I think Tony mentioned about how or in the opening statement about how the rich countries are actually have cornered almost all the doses available for COVID and leaving us behind. The countries who are poor, who have more vulnerable populations than the developed countries. But nevertheless, the countries with more vulnerabilities are also the countries with less access to vaccine. And this is again very unfortunate because this is we have this in the face of our burgeoning death. For example, from the data that was shared to me from the Freedom Death Coalition and as they sourced from the Department of Finance, total of financing agreements meant for COVID-19 responses of April 2021, for example, have reached 15,000 million, so $1 billion, sort of thing. If you go to distribution of it, it will only be like 13,000 budgetary support loans. Project loans is 2,150 million. But look at the grants. Actually, the grant is very small, only 26.74 million of the total loans that we have actually acquired or have entered into agreement to address the issue of COVID-19. And coupled with that issue of debt is another issue about the way our government is distributing its national budget. We have, for the 4.5 trillion budget for 2021, we have 1 trillion for build program, and we only have a very small, almost like negligible amount for as far as the trillion of budget we have in terms of COVID-19 vaccination. That's only 2.5 billion compared to the amount of money that we are providing for the build program of the government. At the same time, government secured new loans for the procurement of vaccine, as I mentioned earlier about the loans that we entered into to support our vaccination program. And just today again, on top of the 82 billion allotted, it says that both senators, I think the two senators, it will be Drilon and Pangmin, expressed concern about Budget Secretary Evisido, who said that the government needed an additional 25 billion to complete the vaccine rollout on top of the 82.5 billion allocated for vaccine procurement. And where will we get this? I'm sure a lot of this will again be loans and then increasing the government debt burden that as of January 7, 2021, as reported in the Inquirer, swells to 10.13 trillion. That's for the local borrowings related to basically or affected in a lot of ways by the COVID response of the government. So these slides would show you again all the types of borrowings that the government have entered into. And we are actually, the sad thing is we're actually borrowing more to pay more of our the principle for our needs. We are borrowing to respond or to pay our debts, which is basically a debt sentence. So that burden has tremendous impact, we know of that, on ensuring most basic determinants, like making sure people have clean drinking water, that they have adequate sanitation, adequate nutritious food, and environmental health and hygiene. Where will you get all those if my big chunk of your budget is basically to pay for the debt? And that also that burden will further ensure that people's normative rights to health are made available, like availability of vaccine, availability of quality vaccine, its accessibility. As you notice, while NCR will have about 6.4% of vaccination rate, we're looking at a 1% coverage in all of these areas in Mindanao and the Visayas. Say 1 to 2% coverage. And that will not in a way impact a lot in relation to controlling the spread of vaccine. And of course, acceptability, quantity, and quality. And this is despite all the debts that we are incurring. So as we know, the debt burdens of the Filipino people will undoubtedly multiply in the face of continuing impacts of COVID-19. And that would include deepening long-standing social and economic issues. And this will even slow down and make uncertain our ability to roll out vaccines in not only in the national capital region, but also in the other parts, especially more of the remote parts of the country. So in this, we are supporting the push for the cancellation of debt services, especially for 2021, so that our governments can provide or can use this debt servicing money for providing pandemic response without incurring another layer of debt. And we also support the effort to reject false solutions being pushed by the world's richest countries and supported by multilateral lenders, because the debt schemes are very short term and mostly covered only the very, very poorest country and only those countries with Philippines. And on the Philippine, other issues of the Philippines is basically of the long-standing practice of automatic appropriation that started by the Marcos regime, when the government will always automatically appropriate budget for payment of loans. And that would impact, and again, that will be in the 2021 budget. Big amount will be for payment of debt amortization. And we have to borrow for COVID. That's the thing, right? You borrow for COVID and you borrow to pay the debts. So in the Philippines Freedom from Debt Coalition and all the other networks affiliated would like to call for cancellation of all illegitimate debts. And as just we heard lately, the last few days, that there are big issues related to transparency of our utilization of money for COVID and even for vaccination. So maybe a citizens audit should be allowed to move forward so that we can look into all these issues related to borrowings and its impact on the bigger aspect of life for the Filipinos, including health and our response to current pandemic. And on the medical action group also, we would like to move further to channel debt payment to strengthen public health infrastructure and financing of universal health care, and probably strengthen vaccine research and development capability so that we can develop our own vaccine. We have our National Institutes for Health. We have one of the world's, we have the most number of medical schools in the country, and we have good scientists. And I think it's the only way for us to go forward if we have enough money for this research and development. And where can it come from? Or where can we get it from? We can get it from cancellation of our debt service and ensure a free coverage of COVID-19 vaccine and increase budget allocations for determinants of health. But I said all of this can only happen if the country and the government would be part of the global universal call for debt cancellation, especially in this time of crisis. Good afternoon, magandang salamat.
Maraming salamat po, Dr. Nemuel Fahutagana, representing the Medical Action Group in the Philippine College of Chest Physicians. Yes, thank you so much for passionately delivering that presentation as well. We all truly need to act urgently on the reality that the countries considered to be more vulnerable are the ones that do not have equitable access, and even worse, cannot afford them. And access to vaccines should not cause further suffering in the form of deaths and the further negative impacts caused by them. and of course, considering the platforms, systems, and pathways forward that need to ensure access to these vaccines for everyone, everywhere, no matter who we are or where we are. Thank you so much once again, Dr. Nemuel Pahutagana. And thank you as well to our participants and to everyone joining us today. Thank you for your thoughts and your questions. We'll dig deeper into them a little bit later. Now let's hear from our next speaker from Nepal. Arjun Batarai is the Deputy Speaker General of the NGO Federation of Nepal, a national umbrella of 6,500 NGOs in Nepal. He is also the Global Council member of the Global Call to Action Against Poverty. Here to talk about the state of COVID and vaccines in Nepal, let's all welcome Arjun Batarai.
Thank you very much and good morning and namaste from Nepal. Dear media colleagues and CSO activists, I'm actually going to share my short statement I read and I think it will be save the time. So I'm also coordinating this rapid response task force, which is working across the country to support and to respond to the COVID-19. So this is my short statement, and I think after this statement, you can ask question for me. So after several months of relatively low daily cases in Nepal, COVID-19 cases began to rapidly spike in mid-April, increasing constantly from 152 on 1st April and to over 8,000 per day last of the month of the May. Despite its relatively small population of 29.5 million, Nepal currently finds itself among the countries with the highest daily number of the cases in absolute term, and over 45% of COVID-19 RT and PCR tests are coming back positive in nowadays. So it is number is surprisingly very heavy. Latest update from Ministry of Health that the total numbers of infected are 8,02,736, as well as recovered 5,04,530, and the date 8,098 till June 9 at 6 p.m. Nepal time. It means yesterday. And every death ratio is 100% per day in Nepal now. And Nepal launched its vaccination drive on January 27 with the AstraZeneca type vaccine manufactured by the India under the brand name of the Covishield. The campaign was launched with the 1 million dose India had provided under the grant assistance. At that time, the virus had claimed 2,070 lives infected, 2,70,092 across the country. Around the 4,30,000 frontline workers, health workers, supporting staff at the health facility, female community health volunteers, security personnel, sanitation workers, elderly people living in care homes, and prisoners were listed as priority groups for vaccination. After the first round of the first phase was completed, the government said journalists and diplomatic staff could get the vaccination. From March first week, the government decided to buy 2 million doses of vaccine directly from the Serum Institute of India at the $4 per dose. The delivery of the first consignment was shipped as 1 million doses arrived on February 21. The second phase of vaccination drive had come to halt as the Serum Institute had not supplied the remaining 1 million doses so the government said that vaccination campaign would resume from April 17. However, the second phase of vaccination was started after the 348,000 doses of Covishield arrived in Nepal under the World Health Organization that is the COVAX facilities. After the Serum Institute is unable to supply committed doses, and the Nepal government in emergency used approval to Sinopharm Verosil on February 15, and China had promised 1 million doses the Sinopharm vaccine under the grant system, and the 8 lakhs vaccines arrived in Nepal on March 29. The government said that all the citizens have above 65 years of age would be vaccinated in the second phase. However, only around 1.3 million people were vaccinated across the country. Now, third round of the vaccination started from the 7th June, targeting to 60 to 64 years old. We have around 8,05,000 population of this age. However, this Chinese vaccine will cover around the 5 lakh population to vaccination of both those. In other hand, till around 1.3 million people are waiting for the second dose Covishield, and those people are still wondering when they will get the second dose of vaccination, because their Serum Institute not provided the vaccination and also already cancelled the agreement. According to Bloomberg database, only 2.8 million doses given to the 4.9% of population of Nepal. So in fact, still large number of population are left behind for the vaccination. The Health Ministry has estimated the cost of the bringing the COVID-19 vaccine at around 60 billion Nepali rupee, which means $5.5 million, including the cost for the storage and other facilities required to keep the vaccine safe. The cost was estimated based on like $10 per dose of vaccine. So the Nepali government expected to get 20% of the total required vaccine from the World Health Organization under the COVAX program. To date, more than 14.3 people globally have been vaccinated, but almost still left behind from the marginal community, poor women, disabled, LGBTIQ, Dalit, insensitive youth, children, and people who have not access to the direct government mechanism. Moreover, many wealthy countries have ordered 2 to 3 times as many vaccinations as are actually required by their population, and some are even set to the receive vaccine from the COVAX facility, which is many developing countries still struggling to receive the vaccine. The Nepal government and even the head of the state, right, Honorable President, is appealing and requesting many countries for vaccine support. However, there are not good news till date apart from the Chinese government. But I do think that inequality in the way we measured and record this pandemic have direct implication for how it is understood at the time, how it is responded to, and how it will be remembered. Low-income countries are often more reliant on COVAX from Gavi, the Vaccine Alliance, and the Coalition of the Epidemic Preparedness Innovations, and the WHO, rather than the big pharma companies like Pfizer, Moderna, or Oxford AstraZeneca. This could lead to the delay rollout the vaccine, since COVAX supplies could potentially be slower to arrive to least developed country like Nepal. Should this global inequality over vaccination continue, this could also extend the opportunity to rich countries to utilize vaccine diplomacy for the purpose of boosting their geopolitical clout. China, for instance, has secured deals with the various African and Asian countries to roll out its Sinopharm and Sinovac products. Also, the United States said that it will be distribute 7 million COVID-19 vaccine with Asian countries, including Nepal. Also, India and Russia and other countries, vaccine producing countries, are also using the vaccine diplomacy for least developed countries like Nepal. With this sum of the geopolitical diplomacy and unfair vaccine trade, we people are demanding for vaccine to all citizens. However, still we are not getting any trustworthy mechanism at all till date. Finally, we civil society of Nepal raising strong voice for the people's vaccine and coin a thought-provoking slogan already. After the government is declared parliamentary by-election on November, our slogan is no vaccine, no vote, 2 vaccine, 1 vote. Thank you very much.
Thank you very, very much, Arjun Bhattarai, Deputy Secretary General of the NGO Federation of Nepal. Now, we cannot stress enough, of course, the urgent need for equitable access, and not just that, of course, the infrastructure and the systems moving forward. Now, I'd like to share some staggering facts that were actually released recently in a press release relating to what we're discussing right now. New calculations from the PeoplesVaccine Alliance found that in the last month, people in developed countries were 77 times more likely to be offered a vaccine than those living in the world's poorest countries. Now, many developed countries are already vaccinating people at a rate of 4.6 million people a day. And if this rate continues, everyone living in these developed nations could be vaccinated fully by the end of by the beginning of 2022. Now, at the current rate, vaccinating about 63,000 people a day, it would take low-income countries 57 years to reach the same level of protection. Urgent action is needed right now. Now, we've already heard from the representatives of India, Indonesia, Philippines, and Nepal. Now, our next speaker will be talking about the COVID situation of Myanmar, which is also facing a complex crisis. Now, she has more than 15 years of experience in the development sector and has worked with Action Aid Myanmar in various humanitarian missions and, of course, for management and leadership roles for these humanitarian teams, the governance team, and the women's rights team before heading the programmer, policy, and advocacy department of the organization. Without further ado, please welcome the head of programs, policy, and advocacy of ActionAid Myanmar, Kaing Zar Lin.
Thank you. Thank you, and welcome, and greeting for welcoming remarks, and greetings to all. Yes, I must apologize first that if my presentations put further stress to the audience today, but I'm also very much honored and glad to have this space and having opportunities to present in this forum. So may I just despite I'm taking the space here, I'm much more presenting this as a civil society actor and more as a concerned citizens of Myanmar. So just to clarify, this does not represent the opinions of ActionAid Myanmar as an organization. So I would appreciate that acknowledgement. So if I may start with, as the other colleagues has presented, this is a general figures that we can all see of total tested in Myanmar is about 2.6 million out of our 54 million populations. To date, our total positive case numbers remain at 144,000. While the recovered case are also 132,000, not very bad, and the current active case number are around 8,000, as you will see. Sadly, we have lost 3,000 people in this pandemic since last year. As of now, as of June, total vaccinated number, if we summarize, is 2.99 million. That means almost 3 million to date. So the thing is, in Myanmar, as some of you may be aware, my presentations have different shift and slide the slope in Myanmar. So as of January, so as this pandemic started in 2019, late or early 2020 throughout, and as of January or early 2021, the government has committed or has ordered about like 30 million doses at least in our capacity. Of course, it was following to the starting of 1.5 million doses gifted by India, and the government ordered 30 millions, and then there were around 300,000 Sinovac was also promised by the China government in January 21 during their visit to Myanmar. So given this background, the things that sudden happened in 1st February is this: why the people are isolation or stay at home, but this is a mess. People have to come out on the road in resisting to the this military coup happened in Myanmar on the date of 1st February. And apparently the graph, as you are seeing above here, the earlier part uprising at the capacity before 1st February of the testing and the case that the first 2 wave of COVID situation in Myanmar being under control. But then unfortunately, after this slight sliding down towards all is after 1st February, that definitely limited the capacity of testing and no COVID measure controls being observed significantly. So just recently, as of June 4, our Yangon routers also quoted this: coronavirus testing collapsed after that 1st February coup in Myanmar, whose government had brought 2 waves of the infection under control. So since this coup happened, many health workers joined a civil disobedience movement to protest against the coup. So a slight specific number, if we clearly see, is this is the figure stated of testing as of 31st January, the night before the military coup, which is generally an average around everyday testing 16,000, reaching to, as of like June 8th June, day before, on an average of 2,000 maximum of testing capacity. Of course, the number of positive are still increasing and found. So this is just to notice and acknowledge that testing capacity has significant down in the current period in Myanmar. So of course, we do expect the COVID third wave, because in the recent reported case are more in that through the border. So Myanmar has reported 122 COVID-19 positive cases. On June 3, its highest, actually, our highest in our over 4 months period. Most of these cases are from the Chin state, which is the border that Myanmar share with India. So there are some media and references that I have put. And on May 29, the military regime issued a stay-at-home order for Tongsan in Chin state, in that around the area. Jammu Kalay township for Sagain region, of India. But at least in that Chin and the India border, there are some measures put in place recently. But in general, what's happening with the vaccination program in Myanmar sadly is, soon after that military coup happened, there are COVID centers being shut down right after February, but there is also one continuing. It is facing challenges in terms of maintaining its functioning of the center for vaccination. As the majority of the health sector move into the civil disobedient, the vaccination program has been very much distorted. And now, although it was planned in terms of prioritized criteria, etc., within the capacities that we could do, but vaccination now is not conducted by criteria anymore since late February. So, of course, on the other hand, everybody can take vaccine, but the question is, who are getting that? So, on the other factors that we are noticing is healthcare workers having done the first dose. It was before February. Then again, they are resisting to this current political leadership and changes in the country. The military or the current regime also use the vaccine to make the health workers to come back to work or to stop practicing civil disobedience movement. Actually, there is no clear evidence that I could point out, but mostly these are through friends who are working in the public servants, and they are called and they are forced to come back to their work with that reason of COVID vaccine to be continued. So, and on the other side, people acceptance side, I would say, people are also turning away from the vaccination programs. So there were a few similar quotes coming out during this recent period is, I will not get the vaccines provided by the terrorist regime because they are murdering hundreds of people and I don't trust them. So this is some sort of public voices coming out recently, of course, which is very much worrying and concerning in terms of from the perspective of controlling, managing, responding to the pandemic in our country. So there were also big questions already starting vaccine is made only eligible to people who listen to the current regime or the people who does not join civil disobedient movement. Is it fair or is it just, etc. are also being asked because this targeting of priorities for health workers and elderly persons, etc. all being forgotten. So actually this is almost end of my slide, almost to the end is the bigger questions in Myanmar situations right now is would vaccine really reach to vulnerable populations? Is some of the news and article, these are also reflecting the people's concerns and the situations in Myanmar, is moving away from prioritizations to free for all. In a sense, it's very good to hear, but the reality and the case there is that former COVID-19 treatment center, which was actually shut down after Wanta became largely unable to test for the disease. And then they began offering vaccines for the elderly on the March, which is as part of prioritization exercise or as of the vaccination program. But after just 300 people showed up in the center, then in the following days, then there is announcement is that the center they are going to offer the jabs to anyone age 16 and above. And so then from the analysis, people are saying as of the moment, mostly those days we were saying there are so many cars parked in that sector to get vaccinations, mostly from the rich and the middle, whoever who can reach there and able to afford that. So of course it's a free program, by the way. So this said, from the analysis from the volunteers working there, they said on an average around 1,400 people taking that every day since then. Now they have reached, according to that center, but in terms of age-wise, has been, and they said most participant has been under the age of 65, with about half of them between the age of 18 and 40, and 30% between the age of 40 and 65. That leaves just 20% of their targeted priorities program before have been set. And now they are saying they are getting lost of how to analyze what's planned, what's reached, and what are the impacts. And another media or news that I could pick up just to share here is the pandemic response has become politicized. So the evidence says instead of receiving 30 million doses of the Covishield vaccine that we have ordered, actually there is very limited information around what's happening around those ordered. Actually, Myanmar has only acquired just 3.5 million. And according to the figures as of now, or as of April 21st, it's just 1.54 million people had received their first shot. And the second shot, the people are only 340,000 has returned for their second dose. So we can't imagine the effectiveness of even those numbers that we are talking today. And apparently after coup, there are a number of people who are hide and run and being chased after, or they do not want to go back to their work in the health sectors, etc., or included too. That's the situations in Myanmar generally. So while I am acknowledging the other colleagues, other countries has presented with very specific, very inspiring data, facts and figure, the government commitment, how much worry in terms of the national debt in concerning over that, etc., all very much inspiring. And I really appreciate that. Of course, in Myanmar, those figures that exist are as of the moment very vague, and other situations, whom to call the government is the context that we are all in. So just please bear with us. And I said, so it is very unfortunate nowadays in Myanmar is very much conflicted by COVID-19, is conflicted by coup data and vaccination with its availability, accessibility, acceptability as the people are refusing, as I had presented, are all at very big question marks. And even before the questions come for affordability as of the country, very poor country, I would say. So we already end up in many other reasons. So anyway, so I would like to conclude with an upward trend of whatever we have is the current rate of the number of people who had received at least one dose of COVID-19 vaccine as of May 12th or May 13th. According to this figure, you can see there is an upward trend from January 26th, but that represents 3% of the population. I do notice that we are not very much different from the other neighboring country as Philippines presented, Indonesia presented, based on the population size we all have. So I would like to conclude the presentations from Myanmar from this aspect. And thank you very much, all of you.
Thank you very, very much, Kaing Zar Lin, Head of Programs, Policy and Advocacy of Action Aid Myanmar. And what a truly painful question to ask. I mean, it almost seems illogical to even ask the question, would the vaccines reach vulnerable countries? It actually makes me emotional just to think of saying, would it reach? I feel like the question we're supposed to ask is when, and the answer should be now. And this really means lives every single day. And I cannot emphasize any further what Kaing Zar Lin just mentioned: availability, accessibility, acceptability, and affordability. These are all such crucial aspects of what we are facing together today across the world, especially in vulnerable countries and developing nations. Now, thank you so much once again to all of our speakers from India, Indonesia, Philippines, Nepal, and Myanmar. This time, let us hear from our speaker from the People's Vaccine Alliance in Asia. She currently works in the Development Finance Program of the Asian People's Movement on Debt and Development, a regional campaign alliance focused on issues of climate finance, public debt and tax, and fiscal justice. Based in the Philippines, she is also a board member of a national economic policy and advocacy organization, the Freedom from Debt Coalition, to present the charter and statement of the People's Vaccine Alliance in Asia. Please welcome May Buenaventura.
Good afternoon from the Philippines, and very happy to be here, but also very, depressed and sad at the gross inequalities that we've heard from the countries. And this is really at the core of why different CSOs across Asia have come together to form the People's Vaccine Alliance Asia. And it has developed a charter that is available online. And in this charter, it highlights the salient points of why we are really pushing that this be raised as an urgent issue. And from the World Health Organization itself, we know that no one is safe until everyone is safe. So recently, there have been statements that we are on the brink of a moral and ethical catastrophe because of the sheer inequalities in access to this vaccine. And it's not only an ethical dimension, an ethical imperative, but also a justice imperative. So as we've already heard from the many countries, there's really this urgent need for people's voices to state more strongly the importance of vaccine equity. And in the face of how developed countries are hoarding much, much more than what they need, in the face of the mounting debts that countries are piling up in order to access the vaccines, the need for civil society to raise the pressure, to raise stronger actions on this matter is even more urgent. So I'd like to focus on what the PVA Asia, the People's Vaccine Alliance Asia, is united around as a set of 10 concerns and demands. It underscores, or really underscores, emphasizes the urgency that there is no time to lose. No, every day that passes by that only a few people are vaccinated and targets are not reached, that is a danger multiplied. So what are these 10 issues and concerns and demands that the PVA Asia is united around? So all these are aimed at ensuring the fair, equitable distribution of safe and effective COVID-19 vaccines and to take steps towards just transformative change. So there's this immediate need for the vaccines, but also looking at that as a step in a longer journey of transforming economies and societies, that we address resolutely the injustices and inequalities that have brought us to this point. So first of all, that everyone on the planet should get safe, effective, free vaccines. This is not dependent on any other burdensome fees that people should shell out, especially in the light of the crisis that they're facing. So we call for a fair and equitable global distribution of COVID-19 vaccines, one that is based on the needs of the country and its populations, and irrespective of the country's economic status, bound by human rights, international solidarity, and cooperation. Second is that all countries should prepare a transparent vaccination plan, prioritizing people in urgent need, such as the frontline health and care workers, those with pre-existing medical conditions, the elderly, the poor and marginalized, women, refugees, people living in conflict zones, people with disabilities, those discriminated by work and descent, and indigenous communities. Third is facilitating technology transfer and open sharing of vaccine science, technology, and know-how through certain routes that we can see in the charter, but too detailed for me to enumerate here. Fourth is that many of the health systems in Asia lack the effective and efficient procurement processes and practices, from accurate planning to purchasing to storage and so on. So the World Health Organization and UN agencies must take the lead in securing and providing the necessary technical support to ensure a quick and safe rollout of vaccine programs. Fifth is our appeal to the vaccine producing countries to shift away from their me first policy and stop the hoarding of COVID-19 vaccines and therapeutics. Vaccine nationalism keeps the world in an ever-present state of danger and insecurity. It is irrational and goes against science. It violates basic ethical standards, human rights, international cooperation, and solidarity. So together with the ethical dimension, there's also the practical dimension, because vaccinating everyone leads to a safer world. Seven is our call upon global development bodies and platforms, the UN agencies, government, and pharmaceutical companies to work out a distribution plan for vaccines priced at cost and support countries in investing in production, capacity, procurement, and strengthening health systems. Eighth is that government should invest and work with all stakeholders, including civil society organizations, in creating vaccine awareness, including correcting misinformation and managing fears around vaccination, providing quality public post-inoculation support to encourage people to get vaccinated. Ninth, many developing countries in Asia have historically failed to invest in the public health system. And we're painfully seeing the consequences of that now. And this is also because governments have pursued a privatization path and neglected public health systems. So that must change. No? That must change. We see now the importance of public service delivery, and in this particular pandemic, public health systems. Finally, we look at the sourcing of financing for all these measures. That the additional investment in health should not be at the cost of other public services or result in additional financial and economic burdens for the people. They should be funded from sharply progressive taxes on multinational corporations and the wealthy. We must scrap tax incentives that waste potential revenues. And also we must stop the bleeding of financial resources through illicit financial flows. Secondly, the one underscored by Dr. Fahotagana is that developing countries, as they face serious unparalleled fiscal challenges that will be felt for years to come, have also made known their demand for debt cancellation. Debt cancellation frees up resources that should be invested in health systems, vaccination programs, preventive measures, and other essentials. No new debt mechanism should be created for investing in vaccines, which will further intensify our debt problems and aggravate economic hardships in many Asian countries. Donor agencies and governments should not use debt instruments, but provide support through grants for financing vaccination and other needs. So those are the 10 demands and issues that the PBA Asia is united around and is committed to work towards their resolution and realization. So thank you very much for the time.
Thank you very much, May Buenaventura, People's Vaccine Alliance in Asia. And thank you once again to all of our speakers. I know that you have a lot of questions in mind also to our participants today. Thank you so much for staying with us, for listening, and for wanting to be a part of this conversation. We are now about to do our open forum. We have some questions prepared, and we are grateful for these that you have sent in. Now, we would like to ask some of our first question, or the interviewees, to please come on video if that's possible. So one of our first representatives to ask a question is Taneja Kausji of TV3 Malaysia. We welcome you, Tamina. If Tamina is not able to go on video, I actually also do have her question here with me and I can send it out right now. Okay. The question from TV3 Malaysia, Tamina Kaujdi, is what immediate measures will ensure global North governments and global pharmaceutical giants collaborate to ensure vaccine equity? Once again, what immediate measures will ensure global North governments and global pharmaceutical giants collaborate to ensure vaccine equity? Now, this question can actually go out to any number of our speakers, but if it's possible and if she would like to take the question, Ms. Buenaventura, would you like to respond to that question?
I think it was also raised earlier, the issue of the TRIPS waiver.
Yes.
So this is a very significant obstacle, and getting that waiver really opens the path towards a speedier production of vaccines. And secondly, what I also mentioned, a demand from over 500 civil society organizations for the cancellation of debt service payments, at least in the next 4 years. So what does this do? This frees up funds for such responses that includes the vaccination and also the therapeutics, the equipment, the water and sanitation, which are vital for curbing the spread, such basic things, no? So that's all from my end.
Thank you very much, Ms. May Buenaventura of the Philippine Vaccine Alliance. If there's a People's Vaccine Alliance in Asia, and if there's anybody else from our speakers that would like to add to that question, we welcome your response to that as well.
Antoinette, this is Mustafa from People's Vaccines Alliance. Maybe I can respond to that.
Wonderful. Thank you very much, Sir Mustafa of People's Vaccine Alliance. Thank you.
Yeah, thank you very much. So for immediate actions, one immediate action, of course, is that the rich countries are holding vaccine stocks and they are not allowing export of the vaccines. So as a solidarity at this very difficult moment, it's important that they lift the ban of exporting the vaccine from US and European. So more Pfizer, Moderna, and Johnson & Johnson and other vaccines will be available. The other one is that the rich countries, so these pharmaceutical companies are negotiating with developing countries on a very high price, and that's very transparent deals. So I mean, we recently heard they were talking with Pfizer was talking with Vietnam government. Okay, this is the rate whether you want to take or not to take the vaccine, and it's highly non-transparent. So the rich country governments basically they have the leverage because they funded the research and they control them. So they can pressurize the pharmaceutical companies to have a more transparent deals with the developing countries. And that should not, so the rate should not be more than what they are selling to European Union and the US. They are asking more. So that's an immediate one. The third one that May mentioned, of course, is the TRIPS waiver, but that's not sufficient. So then the next step, of course, is that companies share their technology through WHO created COVID-19 technology access pool, where they share the vaccine technology so other manufacturers can speed up the manufacturing of the vaccines. So I think these are the immediate measures, but also financing is important so that the poor developing countries don't have resources to invest in health. Even if vaccine is available, they don't have paramedics to inject the vaccines. So immediate date cancellation and more resources should be freed up for the developing countries so they can invest immediately in the health infrastructures at a mass level so they can provide a vaccine to all the people when it's available. Over.
If I may also add, additionally, there's also the element of lifting export bans or for the raw materials for vaccine manufacturing, which is an issue of concern for those developing global South countries who do have an element of manufacturing capacity. That's it.
Thank you very much, Ms. Taneja, and once again to Mustafa Talpur, the Regional Advocacy and Campaigns Lead Asia of Oxfam International. Thank you for all of your responses, and I hope that this answers your question for TV3 Malaysia. We shall proceed now to the next question that was sent in by the Straits Times, and this is from Charissa Yong. If you are here right now, we'd actually like to invite you to turn on your video and you may ask the question to our speakers personally, if that is possible. But if not, I can also read the question on your behalf. All right, here we go. From the Straits Times, Charissa Yong. The US has said it'll share at least 80 million doses by June, including 7 million so far to Asia. Now, while China says it's already delivered 100 million doses to ASEAN nations. Now, is China doing better than the US in supplying doses right now? And do you have any preference on where the vaccine doses for your country come from? This can go out to any of our speakers today. If anybody would like to respond, you may go ahead. I believe we do not have any responses yet for this question. We can set this aside and get back to it in just a few minutes. And I feel that our speakers can also gather their thoughts about that one. With that, let's move on to our next question. And this is from ABS-CBN News, Katrina Domingo. If she is here with us right now, we'd like to invite her to come on screen and ask her question personally to our speakers. All right, I will go ahead with a question from ABS-CBN News, Katrina Domingo. Is there an effort to police the pricing of vaccines from SII or S2? How much can a person/government save for each vaccine if predatory pricing was out of the equation? So how much?
Yes.
Now, please go ahead.
So that's a good question. Unfortunately, for some pieces of this, we don't really have truly, since disclosures have not happened on the part of the government, when it's to an extent guessing. Are there any efforts to police? Possibly. India has rationalized the cost of vaccines only yesterday or was the day before, and has imposed a bit of a cap on vaccine costs. But in hospitals, as of today morning, the government appears to have signaled an intention to renegotiate its price with the Serum Institute of India. However, time will show whether this would be enough or it would be a part of the renegotiation. The renegotiation will only push the price further. How much would a true procurement at true cost save people? Well, one can do the maths of it by estimates of those who are in the pharma sector. The true manufacturing cost of the Covishield AstraZeneca vaccine could be as low as 25 to 30 rupees, but it's being sold to the government for 150. It's being sold to private hospitals at 780 per dose. The costs of, again, the manufacturing costs of when the Bharat Biotech Covaxin vaccine was being manufactured, the promise was it will cost less than a bottle of water, but the cost to the government again is 150. The costs in private hospital is rupees 1,400 per shot. So therefore, one can do the maths. 25 versus 150 versus 1,400. There is a fair amount of cost inflation involved. So therefore, for a country of 1 billion people, one can do the maths. It would make much more sense for it to be manufactured and distribution at cost, especially in a country like India. There is an underutilized manufacturing capacity even now in the public sector.
Thank you very, very much for that detailed response, Angela Taneja of Oxfam, India. We are truly grateful. We are going to move on to our next question. And once again, if they are here and would like to ask it on camera, we invite them to. The Manila Times, Philippines. Mendoza.
Hi, good afternoon, Miss Tony. I can't. I don't have video right now. Sorry, so I had to ask on audio instead. I guess. Well, one of my concerns is, of course. I think this was already answered on the chat box, but um, some of course there were proposals from the ASEAN, for example, to pool resources and buy vaccines as a group. There were proposals beforehand, but it was not. It did not happen, or the proposal did not even fly around. So, would a pooled funding proposal for vaccines help in the inequality that is happening right now? And of course, we have in the Philippines, for example, we have we have multiple companies expressing their interest in producing vaccines or here in the country. And our government, the Department of Trade and Industry, the Department of Science and Technology, are dangling benefits for these producers to create vaccines. I heard some tax incentives and all. Would these be helpful or not helpful enough to convince vaccine manufacturers? Because I know vaccine manufacturers have so many qualms about having their vaccines manufactured in a country such as the Philippines without having some concessions given by the government. So, what is your say about these two things, two issues?
We open up the floor to any of our speakers today that would like to respond to these questions by Red Mendoza of the Manila Times.
Can I answer for the question?
Sir, please go ahead, sir.
The first one is related, the first question, what is the urgent step at this moment? From my perspective now is we speed up the text-based negotiation of the TRIPS waiver. It would be really crucial and important because the proposal of TRIPS waiver is already 8 months long in the WTO. So if we can speed up the process and have it finalized, so each country can see about their own capacity to produce, and the idea of those sharing, it could be broader, not only from US or from China. That is my first response. And related to the second question, related comparing the supply from China or from US, already from my perspective in Indonesia, we need both. Because as we learned in Indonesia, the variant of concern in Indonesia need to be learned how the vaccine can be effectively treated this kind of different of virus here. So if in Indonesia, we only have inactivated vaccine-based vaccine from China, and we don't have anything from the RNA-based, mRNA-based vaccine. We need that kind of vaccine so we can also learn if in the long run that this pandemic is create a catastrophe of the mutation of the virus, so we can know which vaccine would work better. So it is not to compare which one vaccine to another, but how the vaccine can complementary. And for the third question related to regional pool procurement, actually this is a very good idea. And we are in the HIV and AIDS field already pushing this agenda in our Asian meeting here. Actually that time for the ARV medicine. But it never happened because sometimes some of the issue, like for Indonesia, our constitution is not allowing on doing the regional pool procurement like this. But if this kind of policy barrier can be eliminated, and this collaboration, South-to-South collaboration or regional collaboration, we believe that it will improve the situation. That is from my side. Thank you, Tony.
Thank you very much, Ditya Wardana of the Indonesia AIDS Coalition. We would like to see if anyone from our representatives from the Philippines would also like to respond directly. Dr. Nemuel Fahutagana, please proceed, sir.
I think the idea of shared um, procurement is okay, but I think it's much better if we really would really equip our countries to be able to develop their own. The thing is, we are very, even when we talk about sharing, we still will be dependent on these mass producers or the big pharmaceutical industry. Meaning, even if we buy together, we pool our resources, still they will be able to dictate the price. I think the idea is, as we are pushing forward, is that equip the countries, especially those in the ASEAN, for example, ASEAN region. Why not develop our own capability to produce and basically make it available? Because we have a very big population. Philippines is 110 million. Indonesia is like how many people in Indonesia? How many people temporarily got measure of pull together then buy, and then next time pull again and buy? When do we start asking these big countries to instead condone our debts, remove our debts, and then develop our technology, and then we produce out? Then we don't have to borrow more the next time.
Thank you very much once again, Dr. Nemuel Fahutagana. Maraming salamat po for that response. And we hope that that answers your queries. Red Mendoza of the Manila Times, Philippines. If we don't have any more additions, we can proceed to the next question. All right. Well, moving forward, we have a question from the Wall Street Journal, represented by Feliz Solomon. If you are here, you may go on video or audio to ask your question.
Hello, can you hear me all right?
Yes, we can hear you and see you clearly. Thank you very much.
Thank you. My question is, there have been some reports of delays in the delivery of AstraZeneca vaccines manufactured in Thailand. And given that AstraZeneca was initially expecting to deliver some 200 million doses for ASEAN countries, I'd like to know, I guess particularly from our ASEAN representatives on the panel, how critical this facility is to overall coverage in Southeast Asia and how concerned you are about these reported delays. Thank you.
Thank you very much. Feliz Solomon of the Wall Street Journal. Anyone from our speakers may go ahead and respond to these questions if you would like. Any of our representatives as well from Oxfam may also jump in to give a response for this as well. If anyone has these perspectives on what's going on and what's the current state of vaccines in the ASEAN region as well.
Thanks, Antoinette. I can go. Mustafa here again.
Thank you very much. Mustafa Talpour of Oxfam International. Please go ahead.
Thank you, Feliz, for this very nice question. So, of course, when COVAX was created, there was a lot of hope. And it was the Oxford AstraZeneca that they promised more share to the COVAX mechanism. But because the AstraZeneca's major manufacturing facility, of course, was in India, the Serum Institute, as Angela mentioned. As the COVID hit India last month, as the Serum Institute could not export, even they couldn't meet the demand in India, so that was badly hit. And the rest of the companies was not sharing the enough vaccines with the COVAX mechanism. So just the brief that we launched yesterday, it says that COVAX has only delivered third of the vaccines it had aimed to by this point of time. So many countries have to run out of the vaccine as supply drive. Now on current trends, the poorest countries will only reach full vaccination in 57 years. What is the rate with COVAX is actually delivering? So now it was good mechanism. It was not adequate. And it also was built on not solidarity, but charity. So it's a very old method, but despite all of these shortfalls, developing countries welcomed that initiative that they will get at least some vaccinations through COVAX. But COVAX, again, on the hypocrisy of the rich countries, not sharing their due share with the COVAX. So the COVAX mechanism has not delivered what it's supposed to deliver by end of this year. So that is a major challenge. So every country has been hit, so does the ASEAN countries. So that is why we calling on more production capacities in the countries. What else on COVAX? Yeah, so I think this is where the COVAX is. So the poorest countries is part, because COVAX, the global distributing vaccine to low and lower middle income countries, is experiencing a massive vaccine shortage. After nearly 100 days since it started vaccine distribution, last 3 months or so, COVAX has just distributed 77 million doses in total in all countries, a third of the 237 million doses planned to deliver. So that is the current situation with COVAX. And out of that, to date, only 52 million COVAX doses has been distributed to poor countries, because the rest has been to the middle income countries and others. So that's not enough. So at one end, when People's Vaccine Alliance is demanding TRIPS waiver and technology access pool, the other end, we are also demanding that there should be more resources for COVAX to distribute, but also sharing the more vaccines to the COVAX. Over. I hope this helps, Felice.
Thank you.
Thank you very much, Mustafa Talpour, Oxfam International. We welcome any more responses from our other speakers. If you would like to add to that, you may do so.
I guess I didn't want to add, since India is the defaulter in this experience, but fundamentally it is critical to ramp, as in that sense Mustafa also flagged. Fundamentally, if there is underproduction, there is underproduction for a reason, and that the solution to that lies in a combination of lifting of IPR and at the same time ensuring availability of materials that are needed to ensure supply along the value chain of vaccine manufacturing. So therefore, if we want to address the gap, let's deal with it at the source. The solution is an IP waiver. The solution is technology pooling. The solution is bringing in the new manufacturers to have surge capacity to ensure vaccines get manufactured.
Thank you very much, Angela Taneja of Oxfam India. And thank you once again to Felice Solomon of the Wall Street Journal. We have time for one more question, and this is from CPRH, Dr. Josh San Pedro. If he's here right now, he may also come on camera or audio to ask the question directly. If not, I can proceed with the question. How can we engage governments that remain silent or pessimistic on the issue, such as the Philippines, yet continue to face scarcity and lack of medical tools to prevent, treat, and contain COVID-19? Once again, this is from CPRH, Dr. Josh San Pedro. And I believe as this refers to the Philippines, we might want to get a response from one of our representatives from the country. We can also hear from either Dr. Namuel or maybe Ms. Buenaventura would also like to give a response on that.
I didn't get the question. I'll check in the chat box.
The question was basically, how do we engage governments that remain silent or pessimistic about the issue, even if there is a faced scarcity and lack of medical tools to prevent, treat, and contain COVID-19? So the question really is, how can governments be more fully engaged into the pathways forward, especially as well in the Philippines, the question was asked.
First, of course, the Philippine government will have to be transparent in what it's doing in terms of the whole program. There's a lot of, I believe, a lot of some confusion relating to information or data, even in the coverage of vaccine and even in the current status of what do you call it, infection, like say infection rate, because one day it will be 4,000, the next day it will be 7,000, the next day it will be back to 8,000, and there's such kind of confusion. So I think this really need to strengthen partnership with the people and especially the civil societies. I think we play a big role in this particular effort. And there's one thing we really forget now. We're forgetting the big role of communities. It would seem that the communities are just being treated as recipient of services instead of participants in making decisions about where it should be shared, when the vaccination should happen, what let's call it contact tracing mechanism should we do, what type of quarantine program should be proposed, because as you would have noticed in the Philippines today, there are so many news where while you bar people, a lot of people we are being very strict on the requirement for immunization. Some people are being seen in the newspaper or in some footages, special known politicians and personalities receiving vaccines, even when they are not yet in supposed to be in that category to receive the vaccine. And we have a very low coverage of, for example, we have a very low coverage of senior citizens. But the majority of the deaths are the senior citizens. But our coverage is less than, at least, I think, less than 25% of our seniors have been covered by I may be wrong in the percentage, but still very low. And where are we in this? Where is the government in terms of really making sure that people are part of the whole process? It's more like we are in control, we know how to do everything, but we don't. They don't, because it's sometimes it's all about politics, all about the economy of it, but never about the people's right to make also decisions about their own health, and even decisions about what vaccine they are to get. These are big issues, and there's one thing really missing now and really very important: the trust. We're losing the trust, and people are losing the trust in the way the government is implementing. Unless we regain the trust, then we will have a very, we have a very low, even if we say we have millions of vaccine coming in, but not the same interest of people, or the motivation of people is not increasing. That's the thing. Maybe the vaccine will increase the number, but the number of people willing to be vaccinated increasing. So how do we make sure that people are participant in the whole decision-making process? That's the only way we can really make sure. And again, as I said, transparency. Where are we? Let's all be honest in terms of what's going on. Let's all be honest where that money is going and how we are using them. Because if even senators are questioning the transparency of government in relation to budget, what more about the people, right? I think that's important.
Thank you very much, Dr. Nemuelfa Hutagana, for that response. We thank all of our speakers once again today. We're running out of time, but we are grateful for your efforts, for all the work that you do, and for everyone that stayed with us this afternoon to join the conversation. I know you have a lot of questions as well that you are waiting to be answered, but of course we can share that in the chat box and hoping to answer them separately. You may also send your queries to Oxfam in Asia and Oxfam Pilipinas and the respective divisions across the world as well. And we thank you once again also for your questions and for your time. We've come to the end of our media forum, but before that, we'd like to ask the members of our speakers and of course, the People's Vaccine Alliance Asia to please turn on your videos and virtual backgrounds so that we can just take a Zoomie or a special photo op just to remember this day coming together, of course, for everyone across the world, especially the most vulnerable. We'll allow Team Oxfam to take these photos. Let's just keep smiling until we get a cue. that we are done with the photos. I'm trying to talk while smiling. All right, I trust that they've got it. Thank you very much. And also, right after this forum, we are inviting all of you to please join our Twitter storm. It's happening right after this in just a few minutes. Please help us spread the word about our call for the TRIPS waiver. Don't forget that, the TRIPS waiver. And of course, access to free and affordable vaccines for everyone, everywhere, no matter who or where we are. The details are flashed on your screens. Yes, I have yet to get vaccinated. And of course, you can also check out the People's Vaccine website and follow and retweet People's Vaccine on Twitter. Now, if you wish to connect with our speakers, kindly follow them or their organization's social media channels. Now, no one is safe from this pandemic unless everyone is safe. We need the urgent actions of governments and the pharmaceutical industry to make sure that enough doses are produced for everyone. Now, the proposal to waive the intellectual property protections for COVID vaccines at the World Trade Organization is a crucial step to make the vaccine free and accessible to everyone. Again, this has been Antoinette Toss, Oxfam Philippines Ambassador for Resilience. And as we move forward with courage and hope, let's make sure everyone knows and uses their voice to tell the world how we need a people's vaccine, not a profit vaccine. Thank you very much. Stay safe, stay strong, stay hopeful.
Well done, our moderator.